there's so much to know. So you can't, I don't know it all. I will be the first to say I don't know it all, but to just at least have a decent foundational knowledge of these things helps you treat your patients, and it helps you put the tools in their toolbox so that they could do better. I hear hygienists all the time getting pushback on, oh, my doctor will never invest in this. Oh, my doctor will never, it's too expensive, blah, blah, blah. It is expensive technology, but it's amazing technology. And there's a reason why the price point is where it's at. You have to come with the information and the science and the reason why behind what you need, and really advocate for yourself to then advocate for your patients. And ultimately you're advocating for the practice. So they should be able to put that all together.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 229. My name is Andrew.
And this is Michelle. Welcome. Glad y'all are here. What's really cool is that we're getting so many more downloads. Everyone is like really into podcasting right now. It's great.
Yeah. Oh, and there's just been so much really cool news in the podcasting space. I know you don't care about it, and listeners probably don't care about it, but Joe Rogan's going to Spotify. That's huge news. And like, what's that going to do for what podcasting looks like? All the videos that he does on, I was looking up on YouTube. He gets like 12 million views of his videos.
Crazy.
And he's taking all that off of YouTube and putting it just on Spotify. So what is that going to do?
Wow.
So, I mean, yes, you're right. It's this.
Yeah. I don't listen to Joe Rogan. I'm not like a big fan, but I also don't use Spotify. So if anybody's going to go exclusive like that, I'm going to be really annoyed.
Well, and that's the thing is like, well, what's going to happen? Obviously, dentistry, dental podcast, none of us are going to do that. Like we're all small fish. Like Spotify's not going to come after us, like knocking on our door, being like, hey, come, produce content for us. But that's still just, man, podcasting it's popular. It's in the news all the time now. So
it's true. And we're glad you guys are with us for this podcast. We have been really enjoying our series on dental implants. And I don't know about you, Andrew, but I am missing seeing patients.
For sure. I'm missing seeing people, which is something I never thought I'd ever say ever in my life. I am
shocked.
I know. I don't know what it is. Like, I think I want to see people on my terms.
Oh, well, yes. Yeah.
And that's it. But also, my patients too. Like, I miss seeing the patients. I miss like seeing the progress. And I think part of it's like a little self-esteem like booster that it gives me all the time when people are getting healthy, and that makes me happy.
Gratification.
But yeah.
It's true. And I had just gotten a bunch of new equipment, and I was trying out new suction units and all these things. And I haven't been able to do that in, 3 months now. And I won't be doing that anytime soon because I'm not personally going to be seeing patients probably until end of June, early July, if that.
Is that when the state mandate is, or is that when the clinic mandate is?
Clinic. That's my particular clinic. A lot of my patients have a ton of comorbidities, and we just don't feel that it would be, nothing is emergency right now. Granted their quote unquote prophy perio maintenance, we do believe it's essential. Like everybody gets a little triggered with that. But I am also doing some behind the scenes things with my clinic, and we're doing home care instructions and it's not me cleaning teeth. My clinic is very supportive in this idea that I have created that I'm not just the tooth cleaner, because I'm talking vitamin D, I'm talking airway. I go through extensive home care instructions with them. And then I was doing biofilm management. So honestly, my goal was never putting a scaler to the tooth or ever having restorative work, which again, I work for an outreach. I'm in a clinic. Like we are not production based at all. We're just more like trying to be there as a dental home for our community. And so if I can get these people to have less disease, that is like a huge, huge thing. And we're not doing cosmetic dentistry. We're not doing implants. We're not doing ortho. We're not doing Invisalign. We're not doing any of those things. We are just there to help our patients. And so if I can decrease the disease by doing home care instruction and letting them have accountability, like that's huge. So I probably won't be creating aerosols and like quote unquote scaling patients for a while because they do have so many health issues. And there's so many other things that I can focus on as a clinician in my clinic.
I would honestly like to know, because I know that really like that particular type of dentistry, dental hygiene specifically, but dentistry is your thing.
Oh, yeah, it is.
I would love to know though, honestly, I don't know if I could be that person. I don't know if that's the type of hygienist I would be. And I would love to know what other people want, like out of the profession. Mm-hmm. I love metrics. I love production. I love all that because it also helps me feel a certain way about achievements and
you can still outcomes. Get metrics and everything. I mean, if they're having less,
but it's different metrics though.
Yes. Yeah. I mean, It's not looking at, I've done this X amount of dollars. It's more like this person is staging and grading of perio, or it's, are they healthy? Are they the people that we suggest to have diabetic screenings and go over to the diabetes clinic that we have attached to us and suggest airway screening? How many of them are doing that? Like you can get metrics from it. It's just different. It's not production based metrics.
Yeah. Yeah. No, that I love that though. I bet there would be a way to easily implement that into the electronic health records though, and create some sort of metrics for holistic health and kind of give them extra points. And then you as a provider get extra points if your patients are doing that, because that means that you're really conveying the message properly.
I know. Well, you think on that because that's not where my little brain goes. I'm more in the implementation of it. Like,
yes.
This is how we're going to do it. This is how we're going to like that one-on-one with the patient. And I mean, honestly, I could sit and chat with my patient the entire time and never pick up an instrument. Like I would actually enjoy that very much sometimes, especially right now when we're about to put on 47 layers of PPE. I'm really excited just to talk about nutrition and diet and exercise and how they sleep. And, even just doing a quick exam with my mouthwatch camera and the intraoral pictures that I take and setting up kind of their accountability and performing that motivational interviewing that we talked about last week with Miranda. And and practicing that because it takes a lot of practice. That would be fantastic. But not everybody wants that. I get it.
Yeah, I'm a little bit nervous about going back. So we're going back probably the 8th or the 15th of June, just kind of depending on what's going on. I feel like my clinic always did pretty good with PPE. I think the only difference is going to be the masks and the face shields. Yeah, I just don't know what's going to be required necessarily with my clinic and then with the state and everything. But like we always had the big, heavy, long gowns that, cinched up tight. And like it was a production to do all of these things anyway. So I'm hoping that because we were already doing mostly right, it's not going to be like, I'm not going to be like sweating so much underneath.
True. And also probably because you were following the 2003 and updated 2016 CDC guidelines, the transition for a clinic that's been pretty on par or spot on, I should say, with their protocols and following standard precautions, you'll probably be fine. It's people that they were at maybe like a 40%.
They were going in with just their scrub top and that's it, like no other gowns, no nothing, like occasional glasses. Yeah.
It's going to be rough. And honestly, I have been also creating the standard operating procedures for my clinic and some others, kind of sharing these things with other people. And the things that I keep hearing from everyone is like, oh, they're just not going to want to do this. Like, it's not a want. Like, why do you not want to do that? Like, I get it. It's hot. It's uncomfortable. Like, and especially in 95, which I don't know if that's here to stay forever. We just got to get through this. Right. But yeah, that sucks, man. It's hard to breathe, all those things. I understand that part, but the other things of like not wearing your gowns, not wearing your mask properly, not covering up, not degloving when you needed to deglove, not transporting your inch. Y'all, like this is 101. This is healthcare 101. And I know that not everybody, well, I also just learned that most states do not require infection control as a requirement for your license renewal.
Yeah, that's yeah, I knew that though.
Well, I mean, I knew some, but I didn't know as many. And
We could have a whole nother big long discussion about what should be required for our license renewals per state, per
Yeah.
why don't I have a restorative function component to my license renewal? It's part of my basic license, and I don't have to take any more courses other than what I took in 2009 to get my license. That's it.
yikes.
Isn't that?
You know,
Yeah.
It's scary. And, you know, it's very interesting to go through all these state requirements and stuff. Like, for instance, Tennessee, hygienists can get, I don't know, this is an arbitrary, like, I don't know what this number is correct, but let's say 6 CE virtually. Like, they can only do 6, but then the dentist can do all of them virtually.
Interesting.
So it's like the divide and how broken our system is in dentistry is, you know, I know we're fighting a lot. There's a big, you know, divide between hygienists and dentists right now. And I don't think it's just because of COVID. I think it's because all of these things have been just under the surface. And now we're just starting to, like, it's bubbling up. And this was just the straw that broke the camel's back in a lot of ways.
Yeah. Yeah.
But the infection control thing, it drives me a little bonkers, because if you graduated in the 80s and the 90s, and that was the last time that you got infection prevention, like, information, it makes all the sense in the world why I read what I read on Facebook.
Well, and then you think also back, part of the other problem is then those people who are not up to date are training the new people coming into the office. And so even if you did have better training, you get kind of indoctrinated into a certain situation where you're not doing it correctly either. So it's,
Yep.
Yeah, it's kind of
and
a
they
bummer.
call that legacy errors. It's a legacy error.
Fancy words.
I know. It's one of my favorite topics to talk about in my infection control courses. Are these legacy errors that get passed down. And I mean, I don't want to make this intro go too long, but there's a story that I always hear in these infection courses that I go to about legacy errors. And I don't know, I feel like I've heard this in the past for a different, like, it was an analogy used to explain a different thing. But so tell me if you've heard this before. It was like, this wife is going to create the Christmas dinner for the first time. And so she's making the ham and she cuts the edges of the ham off. And the new husband is like, why are you doing that? She's like, this is how my mom made it. Like, we cut the edges of the ham off and we put it in the pan and we bake it. And he's like, this doesn't make any sense. Like, why is it helping with the flavor? Like, I don't get it. Like, what's happening here? We've never done that in my family. And she's like, I don't know. Let me call my mom. So she calls her mom, and the mom's like, well, that's what my mom did. We just cut the edges of the ham off. And she's like, but let me call my mom. So they go 3 generations. They call great grandma and they're like, all right, why did you cut the edges of this ham off? She goes, oh, well, you know, that was decades ago, and our oven it wasn't big enough, and we didn't have a big enough pan. So we cut the edges of the ham off so it would fit. And it was just passed down as, like, the daughter helped the mom, and then the granddaughter helped the mom and the grandma. And it was just this legacy error. And granted, it's not like an error, like you cutting the ham off isn't super egregious, other than you don't have enough ham to eat. But outside of that, it's just this thing that's passed down, like, on and on and on and on. And then eventually, like, why are we doing this? No one's questioning it. No one's going through their new instructions for use and their equipment instructions. Mm-hmm. None of that. That's scary and that's dangerous. And that is why you need training for every new hire every single year. And you should have a test for your license renewal.
Boom. Mic drop.
So anywho, I'll get off my soapbox now.
It was a good soapbox, though. I appreciated that one.
Oh, good. Like that's, I mean, it's the story. Have you ever heard that story before?
I haven't. No, that was funny.
But it makes sense, right?
It totally makes sense.
You can think of all the things that's happened in your life that probably fit into that too.
And then you think about, like, us getting in trouble all the time, you and me specifically, because we always ask why. Just ask why.
100%.
That'll fix a lot of those legacy errors. Anyways.
Absolutely.
Yeah, we have an interview.
We do have an interview. So this is going to be the end of our implant series. We hope you enjoyed it. I mean, it started off with Dr. Sully Sullivan teaching us about the placement of implants. Then we had Miranda on that was talking to us about case acceptance, because we got to have it. Like, if they need it, we need to know how to explain it to our patients. And then we have Melissa Obrotka that's going to be kind of the bookend, and we're going to talk about maintenance, implant maintenance. And there's a great Facebook group. We talk about it in the episode, but definitely go check out Dental Implants Uncovered. And it's a study group that you can join. And there's lots of people in there, case studies. Hey, I had this. What do I do? They also had a bunch of lives during the COVID, while we were all shut down, which was fantastic. So you should definitely go check them out because y'all, you can't just treat an implant like a natural tooth. We just can't. We have to have that training. And this kind of goes back to what we were just complaining about. Like Andrew has never been tested since the stuff that he learned in school. How much has changed since then in the restorative world? Mm-hmm. And then what did you learn when you were in school for dental implants?
I mean, next to nothing, right? So.
Right. I would say like what, 0.02% of like plastic probe, plastic instruments, and that's the end of it. Well, there is so much more to these medical devices that we have screwed into people's jawbones. There is. So Melissa and I chat about the maintenance side of it, and I hope you guys really enjoy this last part of our implant series with Melissa Obrotka.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So listeners, to add to the amazing content you've already heard this month on dental implants, we have an amazing educator and implant maintenance guru. I know she doesn't love that term, but I think she really is. And longtime listener, Melissa Obrotka, welcome.
Hi, thank you, Michelle. Wow, that's a very nice introduction. I appreciate that. Thanks so much for being here. I'm so honored to be here. Thank you.
No, this is great. I mean, when I was thinking of doing an implant series, which is insane that it's taken me this long. And I was joking with Miranda that people keep asking, like, when are you going to run out of content? And I'm like, I don't have enough time for all the content that I want to tell people about. And implant maintenance is one of my favorite things to talk about. It's one of my biggest courses that I do. And that's how you and I became like Facebook friends and friendly, and learning from each other was all around implant maintenance. So tell us like your journey. You're a dental hygienist. Like what got you into all of this?
I have always been surrounded by dentistry. My mother actually started out as a dental assistant. And then as time went on, she just kind of moved forward in her career and became an office manager. And then, so that led me to, being around the dental practice as a child and just kind of growing and seeing that side of it from her. And then as I got older, a lot of the people in her practice had always said, oh, you should consider dental hygiene. And I was like, yeah. And then it finally got to the point where my life and it kind of came together. And when I was in college, I initially went to college and was playing softball and got there and there was nothing that was clicking for me in that school. And then, but dentistry was always in the back of my mind. So I decided to leave my softball career behind and go pursue my education in dental hygiene. And I was really not in high school a great student, but when I got into hygiene school, it was like the light bulb went on and I actually loved it. I loved every minute of it. I know people say like it was the worst couple years of their lives. I loved it and I thrived in it. And I graduated my last semester with a 4.0. And that was like a moment for me because I literally was like the worst student in high school. So
me too. I was horrible.
So bad
in hygiene school.
So bad. Little side note, like I played softball my whole life. And I played on a college showcase team in high school, and I had a Notre Dame look at me, and then they saw my SAT scores and they saw my GPA and they were like, we would have loved to have you, but can't do anything with your academics. So that was like a really big turning point for me and my just like, wow, you know what? I should have like buckled down. But when I got to hygiene school, I didn't really it wasn't forced. It was just so natural. So it was kind of like, looking and reflecting back on it now, it's like, wow, I was meant to do this. This was my path. So I love it. I absolutely love it.
And you're great at it. And you are a practicing clinician and also a teacher, correct?
Yes. I practice in a prosthodontic practice in Northern New Jersey. What's really awesome about our practice is that my doctor immigrated here from Mexico. And when he initially went to school in Mexico and trained as a as a periodontist. And then when he immigrated here, he went and got his prosto training here. So we see the implant patient from the surgical to the restorative. So it's an amazing experience to be with them from the point where they come in looking for this solution to their issues and seeing it straight through from surgical to restorative. And then for me to take that baton and carry on the maintenance afterwards, it's pretty amazing. And I started working about 5 years ago at my alma mater in clinic. I'm a clinical adjunct professor. And it's been oh my gosh, it just like reignited my love for this profession when I started doing that, and just seeing their faces when they're frustrated because they're not getting something, and then being able to say something in a way or show them, just getting that, let me hop in and show you. And then the light bulb goes on. It's so rewarding, and I absolutely love it. And I love that a lot of these students I've been able to maintain a relationship with after they've graduated, and to have them come back and just look to me as a support system. It sets me on fire. I love it.
So let's talk about why we are so fired up about implant maintenance.
I think it comes from a place, at least I'm speaking on my own personal experience. It comes from a place where we don't know. Right. So when I started working in this prosthodontic practice 8 years ago, I was 13 years into my clinical career. And I really felt like I was good at what I did. I had confidence in my skills. I had confidence in myself. I really loved perio, but I had been in, GP offices pretty much throughout my career, but GPs some of them that would have a periodontist come in sometimes. So I was able to get that exposure throughout my career. So when I got to prosto, I wasn't really scared. I was like, wow, this is exciting. My next step in the journey. Well, I literally kind of liken it to going back to my softball stuff, like being called from the minors to the majors, because it was like, whoa, I thought I knew what I was doing. And now I literally feel like I have no clue what I'm doing with these people every single day. But it really sparked an interest in me to further my education and figure this out, because these people have made a giant investment in improving their oral health. And some of them would tell me stories on how, we're going back old school when implant dentistry was so new. Some of my patients had bone taken from their hips and transplanted into their mouths, and spent what they said they could have bought another house and what I've spent in my mouth. And hearing all these stories really, made me feel like, wow, I don't know enough about this. And here this person went the distance. I need to go the distance for them too. I need to really up my game and up my knowledge and know how to take care of these people. They're depending on me,
Wow, that's powerful.
I want to see them succeed. They've done what they needed to do. And a lot of times, if we really think about it and we think about how they got there, and Patty DeGangi sparked this thought in me, and I absolutely love her. Just saying, we as dentistry, if somebody lost their teeth for reasons that we could have prevented, we already failed them. So it really just, so it really just kind of changes your mindset. And if you think about how we even got to this place with implant dentistry, it all comes from innovation, right? Dr. Brandemark innovated what we're doing now. And in a way where it kind of was stumbled upon as accidental. So it calls us, at least, this is my outlook on it. It calls us as a hygiene profession to be innovative in what we do, because we're trained on how to treat people with natural teeth. We're not trained on how to treat people with implant dentistry. And it's a totally different approach. It's a whole new ball game. I'm going to have my softball references all through this discussion, but it literally is a whole new ball game. And we have to kind of rewrite the rules and figure out what works. And the past 8 years have been a lot, especially in the very beginning. It's been a lot of me trying things and figuring out, oh, this worked. This didn't work. This was good. This wasn't good. How come the tissue looks this way? How come this looks that way? It was a lot of asking a lot of questions from the doctors. And I was probably so annoying, but a lot of them like to teach us anyway. So mine ate it up, and they enjoyed me constantly why was this? And we saw this case this morning. Can you show me on the x-ray this or that? And there was a lot in the beginning too, where he would say to me, like, don't probe this, like an implant, let's say like number 8, number 9. And like now I know where he was coming from because the implant was maybe a little too large and placed a little too buccal. So he was concerned about the aesthetics. But back then I didn't know that. My brain didn't know those things. So logically, my hygiene response to him was, why would I not probe this? I have to probe it to know the condition of the gingiva and if it's healthy or not. But I get it more now. So it's a lot. And I'm not saying don't probe. Please don't take that away from this conversation.
No, that is not the message in this podcast at all.
Not at all. But it's just understanding the layers of knowledge and understanding the different approaches and how things are done. And that's the thing. There are no 2 implant patients that are the same. They can have these same tooth missing and the same, let's say implant restored in number 9. Like you can have an implant on number 9 and I can have an implant on number 9. It'd be totally different than, there's no 2 implant patients that are the same. So if that's something that I could drive home, we have to approach everybody individually. And it goes back to that something that we are taught in hygiene school is individualized care. So there are a lot of things that our education will help support us with these patients, but there's also a lot that's missing. And I know that our profession is going to get up to speed and we're going to get there. It's just taking some time.
Just taking some time. And, one of the things that I would like everyone to really sit and think on too is because when you look at what our doctors are learning and how much time is spent on the surgical process and the restorative process for dental implants, it's a small percentage of the life of that implant.
Mm-hmm.
We are the ones that are seeing it for the remainder of its life, maintaining it, encouraging home care, doing proper techniques for assessment and also proper in-office maintenance. And you're going to be the real champion in the success of that implant
100%.
By the conversations you have with your patients and the techniques that you treat them and then how you can adequately assess it. And that's it's a weight that you're going to have to carry on your shoulders, but also how amazing it is to know that you have a dog in the fight, because before we kind of felt like, oh, well, it's there. Like, I guess I'm going to have to figure out how to deal with this. And you just sometimes wash your hands of it because you didn't know.
Well, if you think
you're really a champion.
Yeah, you'd have to be, right? You have to be. And if you think about the tools that we have had to utilize for implant patients, like plastic instruments, there's not a hygienist in this planet, I don't think, that would agree with me that they do absolutely nothing. And, so it's hard for us if this is what is put out there and you're not being proactive about educating yourself and looking for more. How do you know what else is out there? Right. So, but implant dentistry really calls us as a profession to, we have to learn more because we're not educated enough when we're in school. And the other thing about implant dentistry is it's so exponentially changing and growing that, and I heard Dr. Fromm say this a few years ago, and I was like, wow, he's so right. Hit the nail on the head. He was giving a presentation about periimplantitis treatments at the Osteology Foundation Symposium. And he was saying, this is what I'm saying now. Don't quote me 6 months from now. Don't quote me a year from now, because my approach could change. He's like, this is constantly growing and changing. And that's so true. Even in the 8 years that I've been in prosto and treating this patient population, how I've approached things have changed. My mindset is 100% changed. I started out with this mission that I wanted to develop a scaler for these patients because we were using these titanium scalers to treat these patients, just not even thinking about plastic because
moving on. Saying nothing is better than going on about that. But my approach at that point was, we have these titanium scalers and they're better than plastic, but they're still scalers that are made for natural teeth, right? Yeah.
And implants aren't natural teeth. They might be designed to look and function like a natural tooth, but they're not. Imitate,
but they're not.
They're not. So everything about the anatomy is different. The way the bone topography around them is different. Everything is different. So why are we trying to adapt these scalers that are, all they are scalers that we use for natural teeth made in titanium? And to me, that was like, this doesn't make sense. This doesn't make sense. because I'm trying to work on these advanced cases. And again, this was my approach early on. I'm trying to debride biofilm on these advanced cases. And, some of the margins from the occlusal plane to where the tissue meets the implant, I'm trying to measure with a probe and I'm guesstimating, but it's like 20 something millimeters of length. So my shank isn't long enough to get there. And sometimes even just where I was holding instruments and cross arch fulcruming and my ergonomics were total crap because I'm trying to get there and get the job done and be as thorough as I can while being as delicate as I can at the same time on that peri-implant tissue. So it's definitely been challenging, and it has definitely made me think outside of the box a lot to properly treat these patients and manage the biofilm, but yet be safe in the process. And I think that's the key component when you're working with these patients.
So can we talk a little bit about some of the very obvious differences and also some of the nuanced differences between implants and teeth? Because you're talking about the bone topography and I was definitely guilty of this too very early on in my career where I was like, just treat it like a natural tooth.
Same.
Just treat it like a natural tooth. It's healing. It's in the bone. We did some very interesting things, 10, 12 years ago when 15 years ago when I started. And now it's a very different understanding. And the thing that I always joke about too is that implants are fragile, which I would love to talk about, like what makes them a little bit more fragile. But they're not so fragile that if they were super fragile that we'd have death by tortilla chips, like constantly, right? They are in the mouth, being used to masticate and chew up, like a strawberry seed would end the life of an implant.
Exactly.
So yes, they are fragile, but you can't tiptoe around this thinking that you're going to kill an implant if you probe too hard or if you put an instrument to it. You have to be cautious 100%, but don't freak out. Or because if they're chewing tortilla chips later that night, you're not going to do any work.
Right.
In some cases.
Right. Yeah.
So can we just say what's the pretty obvious differences between a tooth and an implant?
If you think about, let's say, a molar, because again, there's so multifactorial. There's so many different implant patients we could address. But let's just take like basic molar. Let's say number 14, right? Patient loses the tooth. They restore it with an implant. So if you first want to think about it, we have a multi-rooted tooth that's getting replaced with a single screw, right? Root form shaped implant. It's singular, it's circular, it's a screw shape. So how is the bone going to adapt around roots versus that are three-dimensional, right? And yes, an implant's still three-dimensional as well, but the bone is just not going to adapt the same way. So the fullness of the roots, we're not going to have that with an implant fixture. So now that's going to affect the interdental space, right? And the way that depending on the restoration, the way the contact points are between, 15 and 13, if they have those teeth present in their mouth. So it just keeps on going and going. And then we also have to think about the tissue. What was the tissue like? Why did the patient lose the tooth? Was periodontally involved? Was it failed endo? Was it internal resorption? Why did we lose this tooth to begin with? So the risk factors are also in place there. And then if we take it a step further back and look a little bit further, we also have to look at the patient's systemic health and what are their risk factors? Is this patient diabetic? Is the diabetes well controlled? Was this implant put in when the patient was healthy and now they're, 20, 30 years into their lifetime and now their health has changed, and how is this affecting the lifetime and the longevity of the implant? And I've got a lot of patients that I've seen, just over the past 8 years, they're aging. They were in great health and doing well when I started working with them. And now they're older and they're in an time of their life where their dexterity isn't that great. And in some of these cases, I'm seeing them every 1 to 2 months because they can't do what they need to do anymore to take care of themselves. But I'm totally digressing. So anyway, those are some of the key factors in the changes of the way the bone and the tissue are going to adapt from a natural tooth to an implant. And then we have to be prepared, for what's the cleansability of this restored tooth too. Is sometimes, the emergence profile is very bulky on the buccal, but it fits nicely to the tissue in the lingual or vice versa. So that can create issues with adapting their brush and debriding biofilm, or, what are we going to use? I always show my patients when they first get their implant restored, and I take that final periapical, I bring that PA up on the screen and I just show, see this space here? We're going to ask a little piece of string to clean that. And guess what? It's not going to do the job. So that's when I introduce my interdental brushes to the patient, and we talk about using an oral irrigator and disrupting biofilm. But again, being mindful of the integrity of the tissue. I don't want them going crazy, because they're going to do more damage than maybe an untrained hygienist, new hygienist would with a hand scaler. We got to think about these things too. So there's a lot of differences between natural teeth and implants. The way the tissue is, if you think about the way the tissue adapts to a natural teeth, we have all these fibers that hold the tissue to the tooth. Implants don't have that. It's essentially just like scar tissue, just kind of laying there. So being really mindful of that is important. Also looking at the way that the fixture is attached to the restorative and the abutment and the depth of the abutment. Is the implant tissue height? Is it bone height? If we have a really deep abutment, biofilm can just sit in that tissue, and the patient, if that abutment creates what we call a pocket, quote unquote, which could be 5-6 millimeters deep, how is the patient going to manage that on a day-to-day basis, right? And then we could have some issues with the tissue because of that. So there's so many factors that are involved, and it's just really getting to know the parts and the components of implant dentistry and understanding the surgical aspects and where the implant is placed and the depth. And there's so much to know. So you can't, I don't know it all. I will be the first to say I don't know it all, but to just at least have a decent foundational knowledge of these things helps you treat your patients, and it helps you put the tools in their toolbox so that they could do better, because it's the 80-20 rule. And I tell them that too. 80% is what you're going to be doing at home. I'm only here to help you 20. You can come in once a month. That's fine. If you're willing to pay for it, I'll see you. But it's really what you're doing at home. And I got to set you up for success. And then we just tweak along the way. So we see what works, we see what doesn't, and we just make those fine tuning and adjustments along the way. Really using your disclosing has been a tremendous help with that, with my patients.
Yes. That was probably one of the worst things I stopped when I left hygiene school.
Absolutely. You know what? I got to say too, I graduated, I hate to say this out loud because now you have a timeline on my age, but I graduated in 99, and yeah, we covered it and stuff, but it wasn't, it's always got that negative connotation. It's messy. It's this, it's that, but it's the technology's changed. It's so much better now. And I make my students use it all the time.
Well, and what I did, I think my connection with disclosing from school was that it was a grading tool. That was kind of like where my brain was for many years afterwards, and why I didn't connect it to patient success.
Yeah.
Afterwards, and also, yeah, it was messy back then. I don't even know what year I'm on, 16, 17 years ago. It was like messy. It was super messy. And I was the klutziest. I am still the klutziest hygienist. I would spill all over everything, and I'd ruin chairs and countertops and my scrubs and all that. But you're right. The technology has very much changed. And now it gives you so much information. You and I both heard Debbie, Z call it a diagnostic solution and non-disclosing solution, because it is helping you diagnose what kind of bacteria that you're having to deal with in that moment. And for me, it takes it out of my hands. It's not me telling the patient they aren't brushing well. You can't deny the colors that are there. I didn't put that purple bacteria in your mouth.
Exactly. And that's what
it was there.
That's what I always say to my patient. No, I'm sorry, not my patients, my students. It's the reason why we want to disclose is because they have to own their disease. They have to own what they are doing or not doing. And then this way they can't deny it. I actually had a patient recently and God bless his little heart. He worked so hard at home on his home care. And I was like, okay, we're going to do this and yada, yada, yada. And he's like, you're not going to find anything. Before I even started, because I'm explaining the whole process. No, you're not going to find anything because I do blah, 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 blah. And I'm like, okay, that's great. We're still going to do it because it makes me better at what I do when I'm working for you. So we do it. And he was so offended. And I finally, I took the mirror down. I said, listen, this is not to insult you. This is not to offend you. This is not to make you feel bad. You're doing all these things and that's awesome. I want to make sure you're doing them right. And that's all this is. It's an educational tool to make sure that the things that you're doing are working for you. I don't want you to be wasting your time. I want you to work smarter, not harder. And that's why we're doing it. So sometimes it's a hard sell, some people, and you have to, and I'm sure you and Miranda covered the whole disc thing when you spoke with her. That's why it's an important piece of the puzzle to understand who's sitting in front of you and understand a way to then communicate with them so they get your message and they're able to then take what you said and learn it and apply it to their life. Yeah, you really do. And I'm so grateful for all the steps in my path because one of the doctors early on in my career, he had me read this book, The Golden Rule, and he sat down and talked with me about how it's important to know how people communicate. And it was such a great message to learn. I was like 3 years in. So it was a great message to learn as a baby hygienist because it really helps you understand people and who you're serving and how to help them help themselves. I mean, that's what we're here for. We're in a service industry, right? We're serving people and we have knowledge that they don't have. And we have to find a way to share and communicate that knowledge so that they can make positive changes in their lives. And that's kind of how
100%
I approach that.
So, we're big fans of disclosing for the biofilm management. And I'm assuming that's kind of the journey you're going down in the story is how important biofilm management is.
Yes. So I completely, going back to my idea, I had this idea about, developing an implant scaler. And I worked on it and it just wasn't moving forward. And it's just funny how the universe works because it wasn't meant to be. So as I'm doing these things, I had actually discovered the EMS airflow unit. And what I was finding before I got to this point was, my scalers were doing okay, but it was difficult. And I didn't feel like I was really getting full removal, especially on full arch cases. And then I was utilizing my ultrasonic with the blue tip. And some of these patients, I noticed it was starting to shred. And I'm like, Now I'm taking my air water syringe and just trying to flush everything out so that those little particles aren't sitting in there. Because I know if those particles get between the peri-implant space, that's not going to be good. And I'm seeing that happen and I'm knowing that this isn't good. So I'm like, great, but what else do I have to really flush all of this bacteria out of my patient's mouth? So I'm feeling frustrated now because my knowledge I'm gaining knowledge on implant dentistry and trying to treat these patients, but I'm finding the conventional tools that we have aren't really working. So I'm thinking, okay, let's develop this. And then I learn about the airflow device and I saw the airflow master Piazon, right? Is that the old one? The master Piazon?
Yeah, I think so. Mm-hmm.
I saw that unit at a convention on the floor and actually Nancy Miller, it just like stopped me in my tracks and I saw her demoing it and I tried to get to the front of the line and see this. And I was like, okay, tell me about implant dentistry and this device. And she's like, oh, it uses glycine powder. So it's good to use on implant dentistry because, back up a little bit. My first exposure to implant dentistry, I was working with a periodontist who came into our office and he would say it was okay to prophy jet them, so we did that. And you saw how nicely it took all the biofilm away, but you also saw how the red river of blood just started to flow when you hit the tissue. And we all know.
Or sometimes the color of the actual implant would change because you were taking some of that surface layer off.
I don't remember that, but I could totally see.
It probably is dependent upon the implants and the surfaces, but I definitely had noticed that. Or if it was a polished, smooth collar.
Right. Now we're roughening it, right? Now we're making it bacteria, just allowing a surface for it to all adhere to, which is the opposite of what we're setting out to do. So, all the iatrogenic damage that we can then cause doing these things that we just don't know don't work is a really important factor in, what we choose to treat our patients with. So, she gave me the whole demo on it. She showed me the airflow. She taught me about glycine powder at the time. That's what we had to use. And she showed me the peak tip for, removing calculus safely without damaging the surface. And she assured me that it's not going to shred like the tip I was using. So I was like, awesome, I need to get this. How much is it? And she told me it was $10,000. I was like, oh, okay, great. So I was like so excited about this technology. And meanwhile, back at the ranch, I had been, doing some research with this glycine powder. And I was like, all right, well, I have a ProfiJet, but they don't make glycine powder, but glycine is what I should be using. So let me just put it in my ProfiJet and see what happens, right? Well, it worked good for, it worked good for about 3 weeks and then I broke it. So yeah, so because it's just not, the device is not made to take that particle size powder. It's just so fine and so much smaller that it just doesn't work. So I clogged the whole thing and I broke it. So then I went to my doctor and I was like, well, since we need a new one, I know what we should get. And I told him about the EMS unit. And then I told him how much it costs. And he was like, are you crazy? I could get a new one of these for $3,000. I am not spending that kind of money. So I was like, oh, okay, all right, I hear you. So then I was like, I know him. He's a technology freak. He loves his technology. We have the CBCT. We have the intraoral scanner. We have the 3D printer. Like, if you're going to do all this for the surgical side, I need the goods for the maintenance side, right? So I was like, let me just have her come in and demo it. So I called my rep. She came in, she brought the unit, we hooked it up. I showed him, he's like, wow, this is amazing, blah, blah, blah. I was like, yeah, so I won't be struggling anymore. We could be treating these patients better, yada, yada, yada. So he goes, all right, well, how much is it? And because he just forgot. And I told him again, and he's like, what? And I said, yeah, it's expensive, but so's 30,000 an arch. Shouldn't I have the right equipment to treat these patients? And it was dead silent. And then he said, get me financing. He goes, just get me financing. And he stormed out of the room. So I've told that story many times because it's a good one. Because you know what? I hear hygienists all the time getting pushback on, oh, my doctor will never invest in this. Oh, my doctor will never. It's too expensive, blah, blah, blah. It is expensive technology, but it's amazing technology. And there's a reason why the price point is where it's at. And doctors they really have to look at this comprehensively, that if they're going to be doing this, they're spending more than this on their surgical endeavors, right? A CBCT machine's like $250,000. So it's laughable compared to what this costs, where this machine, in my opinion, is going to be like an insurance policy for your implant cases, right? We don't want our patients coming back with failures and such. And we know that biofilm plays a big role in that. So if we're able to manage biofilm and then create a good home care program or regimen for these implant cases, are we not going to be able to improve their surgical endeavors and their restorative results? Because we want happy patients tell happy patients, oh, Dr. So-and-so did my implant and it's been great and I love it and it feels like a natural tooth and da-da-da-da. And their hygienist has the most amazing technology and my mouth feels amazing after I see them for preventative care. So yeah, you should come to this office too. Like it's a no-brainer to me. It just makes sense to me.
Yeah.
But I think it's just that us hygienists, we're so afraid of no. We hear no a lot. I mean, if you think about it, we're kind of like, we're very battered and beaten because we really do have a tough job to do, right?
We do.
We're exposed to how many pathogens. And right now, we're dealing with COVID-19 and we're talking about how this is going to change the face of what we do. And it's going to tremendously. And we're the number one on the risk exposure list for professions. Then we have all the ergonomic challenges of our job. And then we have our patients who just don't want to listen to what we say and don't value it. And then we have the doctors who don't want to support us with the equipment that we need, right? But how much of this do we allow happen? We have to stop and think about that. And we have to look in the mirror and be like, what can you do to make it better? And I think that, you have to come with the information and the science and the reason why behind what you need and really advocate for yourself to then advocate for your patients. And ultimately, you're advocating for the practice. So they should be able to put that all together. And even if they say to you, I can't right now, but, give me a couple months or let's work towards this, or this will be our goal by this time this year. I would be happy with an answer like that,
Me too.
So I think us as a profession, if anything you take away from this podcast is, be a power to bring it to your doctor and say, this is what I would like. This is why I would like it. Here's how it's going to benefit the office. And here's the science to support all of the things I just said. So what's the next step?
Love that.
What's the next step that we need to take? And don't take no. I mean, the first time I brought it to him, he said no. He just flat out said no. but I knew what I needed to do to open his eyes. And if he listens.
And I think understanding the business side of it and having that transparent conversation with your doctor is super important. And also, one of the things that Tony Stefanu taught me is like understanding, is your doctor financially or emotionally driven, and kind of appealing your case that way. So what I understand is you're saying that the airflow and using what used to be a lot glycine, and now we have erythritol as the other type of powder out there, is probably the best thing that we could be doing for dental implants in the way of biofilm management.
Absolutely. In my opinion, it just elevated the care that I was providing for my patients. I no longer felt like I was using all the tools in my toolbox, but not doing a good enough job for them. I no longer was worried that, did I just do damage by, scaling this implant and trying to remove biofilm, where, the more we learn and read about biofilm with our scalers, essentially we're pushing it around. We're not really disrupting it, right? We need a tool that's going to disrupt biofilm, and the airflow is that tool for us. I know, yes, we can do it with an ultrasonic as well, but it's not, you could do biofilm disruption with an airflow so much faster and more efficient than you can with any kind of ultrasonic. This way, then when you utilize the combination therapy between airflow and your ultrasonic device, and I use a piezo, then you're really just using that piezo technology to focus on calculus removal. And the whole appointment flows nicer and the patient's more comfortable, and you're so much more efficient at what you're doing. So my motto is really work smarter, not harder. And ergonomically, it has changed me. I honestly don't think I would maybe even be clinically practicing at this point if I hadn't been using this technology for as long as I have. Because I had my orthopedist tell me recently, can you retire? Because of some of the issues that I have. I'm 21 years in, and it starts to get, gets to your body after a while. So
it does. People hearing this are probably getting a little antsy, because it does feel like it is a paradigm shift. It is a shift in how you approach your patient care with patients who have implants. And it's not picking up that scaler first thing, like patient lays back, you're done with your assessment and then straight hand to scaler. It's a flip. It's a change in the flow of that appointment.
Totally.
But the upside to that is, yes, you're going to have to put the work in to like get out of that monotonous routine that you've developed and those patterns that you created, because we all do that. Mm-hmm. But it's going to make your patients happier, your implant patients more successful, and hopefully do less damage to the implant. Because I know none of us want us to create harm to that implant.
No.
We all know our patients just spend a ton of money on it, a ton of time. And I mean, I would feel horrible if I went in there and did something that could harm that implant. And of course, you don't know what you don't know, but now you know.
Exactly. And that's kind of why I laid out how I started, because I didn't know any better in the beginning. And I was doing the best I could with what I got. But the more I knew, the heavier it weighed on my heart that I have to do more. This isn't enough. This isn't good. This isn't how I want to be treating these patients. And it's just my why behind that was, again, they went the distance. I need to go the distance for them. So it's just, really advocating for yourself. And I'm very blessed that, my doctor was so accepting to this and made that financial investment in the practice. And we've seen it come back tenfold, because we've definitely had word of mouth referrals just based on the care I provide with this technology. It's been amazing. And a lot of times too, being in prosto, we'll get a lot of patients that come over from other offices because the GP doesn't feel like they're able to handle the case. And they get an appointment with me once they're done. And, it's kind of a conundrum and I don't mean anything negative with anyone else, but once they have that experience and they say to me afterwards, like, I've never had an appointment like this before. And I'm like, well, this is how we do things here. And I'm happy that you enjoyed this and you understand the value in it. And these are the things I want you to keep on doing. And, when you go back to your other office, just remember what we said, and you can share with that hygienist too what we talked about with your home care and the tools and what I want you to use. And, there's times where he finishes a case and I'm like chasing them out the door. I'm like, wait, let me give you this because I didn't get to see you yet. And my schedule's booked for 4 months. I won't see you. But, it's important that they understand we can't, we have education is the hugest, I think it's the most important part of what we do. And if we're not educating our patients and we're not educating ourselves to be able to give that proper education to them, then that's when you get bored. That's when you start saying, this is, so routine and I want to, there's got to be something more. Well, that something more lies within you. Where do you want to take this? What do you want to do with this? Do you want to be my friend Eileen Prizzi? She's amazing. She always says to me, she's like, and she tells our students this too. Do you want to be a jaw janitor or do you want to be a healthcare provider? I want to be a healthcare provider.
I like that.
Right? Isn't jaw janitor amazing?
Jaw janitor.
It's totally better than Profi Princess.
Oh, shoot me in the face.
But like
I have such trigger words these days, Profi Princess and Floss Boss or two of the.
Wow. That's a good one. Floss Boss. And that's the thing. Like it all comes back to, we have to get off this conundrum wheel. We learn these things in school and think the technology and what we do every day. I graduated in 99. I had a flip phone in 99. I have an iPhone now. Would I be walking around now with a flip phone? No, I wouldn't. Are there some people that do? God bless them. Yes. But that's not how I'm living my life. And the tools and technologies that are in my operatory shouldn't be 20 years old either. We evolve, we grow, we learn. When we know more, we do better. And it's taking the action that's important. Knowledge is part of it, but if you don't take action on the knowledge, then what is the knowledge for? So
true. For the last little bit, I would love to chat about, and I know we've kind of reversed this because normally we talk about assessing these implants and, you and I are both very passionate about not putting a scaler to an implant unless we absolutely have to get that hard deposit off, and why biofilm management is so critical. But a big part of it is also properly assessing your dental implants. And we mentioned that probing is necessary, but that's a part, what I say is the piece of the puzzle, right? Like you have a much bigger picture that you have to figure out. Could you walk us through what an assessment would look like around a dental implant?
Well, again, it's, we have to think outside the box, and we have to know some of the basics and the fundamentals to be able to really think about how we're assessing things. And because implants are so multifactorial, there's a lot to take in and it can get a little overwhelming. When you're really looking at that patient, you want to understand peri-implant tissue so that you know what you're looking at and you understand your approach to probing. There's so much misinformation about probing out there. And a lot of times when people ask me about that, I'll say, and you and I have had this conversation too, look at AAP. What did AAP just put out a couple years ago, right? They put probing in as an assessment. The science shows you that if you do it properly, you can do it in a way that it's not damaging the tissue. And the other thing that we need to know about our peri-implant tissue is our numbers. What we've learned in school with our 1, 2, and 3 for health, it's not the same with implants. The attachment apparatus is completely different. And depending on the implant and the abutment and the placement, that all are key factors in what you're going to see with your measurements in your tissue. What is an important part of doing probing and having a baseline at the restorative insert and then at your maintenance, going forward, is to notice if there's bleeding that's not caused from trauma from over-aggressive probing, if there's separation, and if there's a change in your numbers. Those are the key components with your assessments. And looking at the tissue and really using those tools in your toolbox with assessing tissue and seeing how healthy things look. That's pretty similar. If it's pink as a natural tooth, then we know we're good. If it's showing signs of inflammation, well, now we got to dig a little bit deeper. And then our brains have to think again, okay, well, what could be causing the inflammation? Is it biofilm? How cleansable is this implant? What was the placement of the fixture like? Is it cemented? Is it screw retained? Is there a chance that there's maybe cement subgingival causing this? And I've had cases where they looked healthy. We're like 8, 10 years in, and then boom, now all of a sudden there's a problem. and it's cementitis, and it can take a long time to show up. So in my office, we don't really see a lot of that, thank God. And because of my doctor's perio background, he ends up doing a lot of that treatment. I've been asking him for a few years for an endoscope, and I'm still waiting. And unfortunately, with everything that 2020's got going on so far, I'm thinking this isn't the year. It's coming. But he keeps telling me it's coming. But that's where I would really refer to specialists like Siobhan Healy and Nicole Fortune, because they to me are the gurus on peri-implantitis treatments, non-surgical. And they are really the specialists when seeing that patient population. And there's really, I can't give you a formula. There's no one size fits all approach to treating those cases either. It's like a kitchen sink approach. But it's amazing that there's a lot of hygienists out there that can do that. And that's something that, again, I want to strengthen my knowledge base and know that too. But right now I feel like my wheelhouse is preventing them from getting there. And, really working on establishing a good biofilm management protocol for the patient at home and in the office so that we can try to remove that risk factor for them. And really, again, looking at that bigger picture, you have to look at their systemic health as well and see what other factors are involved. Uncontrolled diabetes are going to play a huge role in the success of an implant or the failure of an implant. There's just so many factors involved. And again, it can be really overwhelming, but if you have little habit changes and it's something that, you want to learn more about, there's so many articles out there. If you read one article with your cup of coffee in the morning every day, you're going to learn a little bit more and a little bit more and a little bit more. And then it's just taking the knowledge that you've gained and applying it. And that's how you can initiate change within your practice. And that's the control that we all do have, but we just don't always utilize or see that.
Mm-hmm. So when we are looking at an implant, because you made such great points about it's a part of standard of care to probe around dental implants. It's more about, we got to think about pressure. We have to approach it a little bit different. And we also can't get all up in arms when it's a 5, because a 5 might be normal for that particular implant.
Yes.
What are some other things? Like, are you doing radiographs, checking occlusion? What else are you doing?
There's a lot in the assessment protocol. Palpating the bone of an implant and just looking for any exudate, taking your radiographs annually, and not just a bite wing. A bite wing is not suffice. Taking a vertical bite wing is definitely what you want to be doing. But in addition to that, you should be taking a periapical, because again, why did we lose this tooth? Was it a failed endo? If there's a risk then that they can get retrograde peri-implantitis, or there could be, residual infection at the apex of now where that implant fixture is. So if we're not taking a PA and we're not screening for that, we don't know. And then by the time the patient's symptomatic, then it's a problem. So we want to be doing those kinds of things on a regular basis. And, making sure that your doctor is also having the assistants take that baseline PA at the insert is so important, because we don't have anything to go by then. They could be probing it, but you want to make sure that your probing is as calibrated as possible within the practice, and that you're all using the same tool to probe. Your doctor can't be using metal and you be using plastic. You're not going to be calibrated that way. So having these conversations, and now is a great time while we're all out of practice because of the virus going on, but having these little conversations saying, hey, let's talk about probing implants. What's our protocol? What's the standard of care? How are we going to do this? And making sure that we're all aware of the pressure in the practice and we're using the same tools so that we can all be on the same page. It's been awesome because my doctor and I both probe very much alike. So, I'll say to him, I see a 7 here, and he gets it. Yep, I dropped right into your spot. And so it's nice to have that calibration. It's a little easier in our practice because it's a small practice. I'm the only hygienist and him and our assistants, but it can be done. So it's something that's an important part of the picture. And just having a protocol that works for your office and doing your research, looking at the AAP guidelines, that really is a good guide to help you figure out what your protocol should be. And checking.
Excellent suggestion.
Thank you. Checking occlusion is definitely an important thing. And if you don't feel comfortable as a hygienist doing that, leave the paper out for your doctor to do it. Have them show you, ask those questions, have that conversation so you can be doing that. And I like to always ask my patients, how does it feel? Are you aware of anything? Does it feel normal? Those are good questions too.
Are you aware of it? Because that's a real telltale sign. If you know that you're implanting,
yeah, that's a problem.
usually because that's usually like, oh, okay. Like you shouldn't know that it's there. It should just become something that you have as a body part.
Right, right. And that's a question that I've developed working with patients too, because when they've had issues in the past, they would say to me like, it doesn't hurt, but I'm just aware that something's going on.
Mm-hmm. So that's a really good point to make. And the one thing that I also want to encourage, because, you and I we started out, I'm not currently seeing as many implants. I'm actually seeing some very interesting ones because they're all done in other countries, it seems now in my patient population. But when I first saw, was treating patients and as a hygienist, like I saw one every day. And now some people might see one a month. And I suggest taking some of these things that you just heard on the podcast and like writing it on a sticky note and putting that sticky note in your op somewhere. So when you do have that patient that sits in your chair and you're like, oh, they have an implant, you don't have to like freak out. Like, what was the thing? What did she say I can't do?
Right.
What was my journey to do assessment? Like, I don't remember what that is. Create that. And there's a lot of resources out there for
Totally.
you. Just put that in a sticky somewhere in your op so you can always refer back. I do that for a lot of things, like certain immunocompromised patients that I only see like once a year. And I'm like, ugh.
Yeah.
I kind of have that little cheat sheet somewhere in my op. So I would suggest doing that so that you do feel confident in that moment, because you turning a blind eye to it, you're doing actually a horrible injustice to your patient.
Absolutely. And supervised neglect is a thing. And as patients,
It's a real thing.
It's a real thing. And as patients spend more and more money on this dentistry and things fail, they're going to come after us. And we've had litigation come through, not our office, but like we were the office that the patient sought care from after the fact. And we have been part of litigation for something. So it's a real thing. It is happening. And don't think that, just because you're the hygienist in the practice that you're not going to be a part of that. Supervised neglect will come back to you as well. So it's important for us to do these things. And we can't, as professionals, we can't just say, oh, I didn't know, or I wasn't taught. That's not going to hold up, and our patients deserve more from us. We have to be lifelong learners. And I feel like there's not a hygiene program in this country that doesn't teach you that. So, it's just, you have to take the initiative as a practitioner.
So true.
To do that stuff.
So true.
And carry it on. One of the resources that I wanted to share too is, myself and Siobhan Healy created a Facebook group a few years ago called Dental Implants Uncovered. And we did it for our fellow hygienists. It was created by hygienists for hygienists, because there was so much misinformation about implant maintenance out in the internet world. So many non-science-based suggestions that were going out there. So we wanted to create a platform that was a great resource for clinicians, and anything that was on there is going to be backed by science. So we love to have members there that engage in conversations and share. And even just like if you see an implant case and you're just not sure on the treatment, and the patient is willing to allow you to share their radiographs or images or information, you can post it there, and you can have a whole panel of people who are experienced with this patient population help share information with you and help kind of guide you on how you could be treating them. And it's a safe place. We won't tolerate any bullying, or
it's a positive place. It really is.
Yeah. We're all here to help each other, because if I can impart some information on you and that inspires you and so on and so forth, and I learn from you and you learn from me, we all are better together. So that was the whole driving force behind that group. So we welcome you to join us. We would love to have.
Yeah, it's great. And there's, like you said at the very beginning, there's not one implant patient that will be the same. There are so many implant companies, so many ways to restore things now. And so we really can learn from each other in these situations, because you might have this fascinating implant case that I will never see, or you might had already seen something similar, and you could help guide me as I find a way to find a health for my, patient that's suffering from maybe some mucositis or something. So I think it is a fantastic resource. Anything else that we can close this implant maintenance podcast out with as far as resources?
Well, the other resource that we have is Siobhan, myself, Miranda Beeson, Nicole Fortune, and Joe Grassmick all come together, and we teach this course called the Implant Care Practitioner course. And what it is a 2-day hands-on course on how to treat this patient population and all the different treatment approaches, and just giving you that foundational knowledge. That's our level 1 course. We level 2 and level 3. We're expanding upon it. It's growing. Siobhan has really done an amazing job putting all these pieces together and really creating this avenue for clinicians to learn. We've got a few things on the books for 2020. Again, I'm not sure how things will pan out, but, things are in the works, and, we're working on making some more information and education available online as well. So that's going to be coming in the future.
Well, you guys also give a lot of courses throughout the country, and I think the Dental Implants Uncovered Facebook group is an incredible resource, and where people can definitely reference back. And if you want more information on airflow, you could always go to ems-dental.com, because they have a lot of videos too, or just YouTube it. Like, you'll see all the videos your heart could desire if you just YouTube airflow and EMS. And even dental implants, you'll come up with all kinds of stuff.
Yeah, they're a great resource. And again, just, their Swiss Dental Academy has so many amazing webinars, so many resources.
You gave one, actually. Yeah.
Yes, I just did one.
That you can
last
still
month.
do. You can still go watch and on demand.
Yep. And a lot of my cases are shared in there. So you can actually see what I work with on a day-to-day basis, and just a lot of the different approaches that are there. In closing, there's so much, with implant dentistry, and we just got to touch on tiny little portions of it. So, I definitely, when you talk about implant dentistry, you can't even do it justice in an hour conversation.
Not at all.
If anything, it's the tip of the iceberg, and just researching and learning more. And there's again, our resource has so many articles and postings that you can really learn from. And it's international, because we have so many clinicians that, we're able to reach and learn from, like Carmen Lanaway and Tabitha Akrate from Carmen's practices in Germany with cutting edge implant doctors. And Tabitha is working in a clinic with zygomatic implants. And so we're able to learn from all of these amazing clinicians that are doing this too in other countries. And the big takeaway that I want us American hygienists to understand is this airflow technology, although it's new to us, it's not new to them.
It's been there a while. Yeah.
They've been doing this since early 2000. So, and the airflow prophylaxis master that we just got a few months ago in the US, they've been utilizing for a couple of years over there. And it's definitely amazing technology. I've had the opportunity to retire my old unit and use this one. And I thought, how could it get better? And it has. So the technology behind it is amazing. I mean, it warms the water. The patients love it. They say to me, besides noticing this beautiful machine in my operatory, they're like, wow, I felt a difference with that. So the technology is worth the investment, because it is better than the older devices. And the handy devices, although they're more affordable, in the long run, they're really not, because the amount of powder that you waste is tremendous with those devices. So I would definitely encourage trying to do your research and your homework to really look towards the prophylaxis master, because it's the best investment, in my opinion, that you can make in your practice.
That's awesome. So where can people reach out to you and find out more information, or if they have questions, how can they find you?
Well, you can email me at melissa.obrotka@gmail.com. And I should probably spell that, because my last name is a nightmare.
How long did it teach me? How long did it take you to teach me? Say your name.
It's funny.
And now I'm like, Obrotka, I can say it all day. But before I was like,
you're like, I'm going to butcher her last name. It's, I'm not even going to say it.
I'm not even going to try it. But yes, spell it for our listeners.
It's
and we'll have it in the show notes too, guys.
It's Obrotka. And I am launching, by the time this is out, my website will be launched, which is melissaobrotka.com. So you could definitely reach out to me there too. A lot of exciting things I'm working on. I'm utilizing this social distancing time wisely.
Good. This is the way to do it. Well, thank you so much for your time. Thank you for all the effort that you put into learning and educating yourself so you can help us be better clinicians in this world of dental implants.
Thank you.
We really appreciate you.
Thank you. I appreciate you and Andrew and all you guys do to share all of us and our niches in this field of dentistry and this amazing opportunity we have to, share with each other to do better by our patients. It's all about the people we serve, right?
Absolutely. Amen to that. Well, thank you. Stay healthy, and we'll definitely have you back, and maybe we can do some Q&A from if anybody sends in. So send in your info, questions. We would love to see if we can do a Q&A later on that.
Awesome. Thanks, Michelle.
So I know everybody took something from that. I just want you also to all remember that this was just a toe in the water. There is so much more. I know Melissa and Siobhan have huge courses. I have a 5-hour course on implant maintenance. There's so much to learn, but don't be overwhelmed by this. It's one of those things that you'll learn as you go, and joining that Facebook page is going to be super helpful. But yeah, I was so happy to finally have an implant series.
Yeah, it's been a long time coming. I was kind of surprised we haven't done it earlier. So from my end, listeners, I'm probably more where you're at on this journey of implants than where freaking Michelle's at. Here's the thing. What I've noticed, I will go to a course and I'll learn a really good tip, one or two things. I'll take it away. I'll try and use it. I don't see a lot of implants still, so it's hard to remember, but then I'll freaking forget. And so don't get frustrated at yourself when you're trying to learn this new system, and know that it's evolving at all times. And so you just have to kind of keep going, even though you took an implant course 1 year, take it the next year and take another one the next year, and just keep learning and be open to multiple people's perceptions and ideas about implants, and do what you're finding is the best. The problem that I have, Michelle, with the gurus of implantology is, man, are they every single one of them exactly right and no one else is ever right. But that's the way it is in dentistry too.
It is. And I'm really glad you brought that up. Yes.
I just want to say, really just kind of be open-minded to everybody about all those things, that things can change and that everyone needs to be taking courses. So,
yes. And also understand, your office, your patient demographic, your doctor, your tools and systems, and they're different. So I went from an office that placed every single one of our implants. I've since day one graduated and went to an implant driven practice. That's where I lived for most of my career. And now I'm in this community outreach center. And guess who's placing these implants? Other people in other countries. I'm seeing a whole new breed of implantology. And some of it, I'm oh, that was actually really well done. And some of it, I'm oh my God, I don't even know how to fix it. I don't know where to go from here. This is the most egregious implant surgery that I've come across. So it's different for everyone, and you're going to be different. So that's why what you just said, Andrew, is so true, because somebody who's up on that stage preaching the gospel, if you don't do anything other than what they do, that's so wrong, because it's different for everyone. Now, I do believe that there are some things that are pretty across the board or pretty generalized, like replacing implants, CBCT scans. I just feel I would be scared not to do that. If you're not probing dental implants, you need to have a real good reason for that. And it's not just that I don't know how to do it or I'm scared of it. I don't know what I'm doing.
Right.
So there are some things where, yes, you have to get on board, because that's just the standard of care. But then others, it's not black and white. And we try to do a really good job of bringing people on that we've vetted. So we know that they aren't coming from a place that is preaching that gospel. And if you're not doing it and they're not, up on that pulpit, we try to be really good about that. But you're right. That's a good point.
That's all I got.
Right. Okay. Well, we hope you really enjoyed this implant series. Stay tuned for more series. We would love for you guys to share this with your colleagues. Tell everybody about podcasting if they didn't know about A Tale of Two Hygienists or any of the other dental podcasts. Also, the Dental Podcast Network that's on, Andrew's little baby that he started. And then I have a new podcast coming out with India Chance called Your Infection Control Team Huddle. So stay tuned for that. It's just going to be a short little series. We're going to do like series here or there. It's not going to be a consistent one like us because this is a beast.
This
has to be nurtured and cared for on the reg. And I just don't have time for that. For anything else. But we hope you guys enjoyed this. Tell your friends, tell your colleagues about this. And we would love ratings and reviews if you would go to iTunes or Apple Podcasts. God, I'll get in trouble. Apple Podcasts and any of your favorite listening apps. We would very much appreciate that. And you can always follow us on any of the social medias, the Instagram, the Facebook, LinkedIn, all of those things, and send us a direct message. And if you want, you can even email us at ataleoftwohygienist@gmail.com, or just go over to our website, ataleoftwohygienist.com.
Well done. That was good.
All right. Well, we hope you have a great week and everyone is staying safe and healthy.
Bye, everyone.
Bye, y'all.